Hi, I quickly wanted to go over chapter 36, alterations in pulmonary function in children. The first part starts off with just the differences between adults and children. The biggest thing here that I think is interesting that you may or may not know is that babies up to about 2 or 3 months of age are obligate nose breathers. So if they have an anatomical issue like choanal atresia, they don't open their mouth to breathe. I think that's kind of interesting. So keep that in mind when you think about young children with a cold. Pacifiers do act as oral airways. That may be related to why they have found that pacifiers decrease the incidence of SIDS. Then talks about here about lung development in the premature infant, how these cells go from these columnar cells to these squamous cells, and also the addition of surfactant, which decreases the surface tension of water and therefore allows the gases to diffuse more quickly through those membranes. Talks about the lung dynamics of babies, thinner chest walls, less musculature, that sort of thing. This one talks about the immune response. So that during the third trimester, you know that the babies require a lot of IgG from the mom. This makes them more resistant to disease. They can help fight it off better with their immunity. This is why we like to do vaccines starting at 2 months, 2, 4, 6 months, because by 6 months most of that immunity is gone. So that kind of helps the baby acquire their own immunity while their mother's immunity is waning. Premature babies, of course, lack that, so that's something to keep in mind if you have a premature baby, and that's why they need to have their vaccines on time. Babies have a blunted response to hypoxia. They have a normal response initially, but they can't sustain it. So they don't really know what's going on there, but it's kind of interesting. And they also have a decreased response to CO2. There's some theories about this. They're kind of beyond what the scope of this class here, but babies also do something called periodic breathing, where they breathe, they'll have pauses of breathing up to 15 seconds, and then they'll breathe real rapidly, which is real common in very young babies. So if you see that, it usually scares parents to death, but that's very, very normal. All right. So next part we're going to go is just disorders of the upper airway. So some of the symptoms that you're going to look for are tachypnea, mottling, bradycardia. If you get bradycardia, you've got some pretty advanced pathology going on. Just kind of be looking for these. Patency, big deal. Remember I talked about that obligate nose breather in babies. So if they have some sort of obstruction, that's going to cause a lot of problems. Congenital malformations, and we're going to talk about some of those here in a few minutes. Some of those need referrals. Some of those are very, very minor and probably don't, but if you're not familiar with them, but we'll talk about in a minute, you need to refer anyways. Snoring and obstruction. So sometimes the babies can have sleep apnea too, or children can have sleep apnea. So if a child is snoring, sometimes if we remove their tonsils, that would help with their sleep apnea. Although, as I pointed out in another presentation, there is some information now that we're also affecting their immune system negatively as well, so maybe we need to be careful with this. One of the big things with babies with their breath sound is that babies remember that their lung and their lungs to their face is not that far apart. So a lot of times you'll have parents coming in saying that they're pretty sure they've got something in their lungs, or they're having wheezing or that sort of thing, because they can feel the vibration in their chest, where it's actually coming from their nose, because their nose is so close that you get the referred vibration. Where you really don't see that as much in adults, but it's there's a lot more distance there as well. So that's something to be aware of. I like this cough quality zone. Hoarse, weak cry, that's a problem. Sometimes, especially with like young babies with croup, they'll have this kind of like hoarse kind of cry. There's some other things here like some anatomical issues that we'll talk about in a few minutes can also cause a difference in cry. Epiglottitis we really don't see very much anymore, thank goodness, due to the HIV, the H influenza vaccine. So that's good. But if you do see it, and I think they talk about that further down here, that's something you want to be very much aware of. Oh, acute epiglottitis. So if you get a kid with epiglottitis, that's an infection of the epiglottis, of course. They are sick. I've only had one kid where I thought perhaps had epiglottitis, although I've never seen it because of the vaccine. But they're leaned forward. They got the tripod-looking position. They are drooling. They have a fever. They are struggling to breathe. This is not a child that you want to examine their airway. You don't want to cause a spasm, and unless you can do trach right away, you do not examine their airway. So if you get a kid, even if it's not epiglottitis, just severe croup, and that's what the child that I had, you're going to have the mother hold them because you want to keep them as calm as possible. You're going to give them some oxygen, and you're going to transport them to the ER as fast as possible. We'll also talk about some other things here, but this is not a child, even though they do need steroids, you are going to inject steroids because what happens when you inject a child, they cry, right? So you don't want anything that's going to compromise their breathing any more than it already is, okay? Bacterial tracheitis, I've seen this a few times, but I work in an ICU, so not something you're probably going to see in primary care, but these kids are significantly sick, so you're probably going to refer them over to the ER even if you don't know what it is. Croup, the common age, well, it says common age from croup from 6 months to 3 years. Now, under 6 months, because they have mom's immunity, so they don't really have to worry about it too much. You can have croup at any age, but it's really not a problem because your airways are big enough for it to be not a problem. Okay, so, to say you can't have it pass in, yeah, of course you can, because it's basically a cold kind of virus anyways, but it's probably not going to be a problem for kids over the age of 3. And actually at the age of 3 we very seldom have problems. It's more the 2-year-olds, 1-year-old, 2-year-olds that have the most problem. The highest incidence is in the winter, and it just causes edema. These kids will have that seal-like bark, and a lot of times this will be worse at night. So you'll have a parent that comes in and they're saying their baby has they're having this seal-like bark. It's the time of year for this to be going on. They're in the age range. You may, if you listen to their neck, hear just a little difference in the sound in their neck with their breathing. And I can't really explain it to you, but there's a difference in the sound in their neck. So listen to some normal neck so you can kind of know what the air sounds like going through your neck. If they give enough of that history, I usually go ahead and treat it like it is croup, because they do tend to have the problems at night, and croup can be life-threatening. Can be. Usually isn't. Usually is not a big deal, but it can be. So this talks about the difference in looks here. Somebody talked about the steeple x-ray that you can see. You can get an x-ray if you're concerned and you want to steeple sign, if you want to check, you can see that on x-ray. I've never done that because I've never had that issue where I'm concerned is one versus the other, but that is something you can do to check and see if there is croup going on, okay? All right. Most times there's no treatment if they're young. Now this talks about giving injected medications. I never do that. The bioavailability of the steroids is the same whether you give it oral versus injected, so I always give it oral. For kids, the less injections you have to do, the better, and you certainly don't want them crying. I'm not sure why this is on here, because this really is something you want to do for severe asthma, where you have asthma that you really, they need some more long-term stabilization from their than their albuterol can give them. So I'm not sure why that's on there. Definitely giving nebulized epinephrine in the office. This is something that's done in the office, in the ER. This is not something you send home with a parent, but this will definitely open them up if they are acutely ill. So if you get a kid that comes in that's acutely ill with like croup, you can give them an EpiNeb, racemic epi, and give them steroids. It takes about steroids an hour to kick in, so you keep them in their office, and this usually will kind of get them through that acute period. The steroids kick in and they can be a lot more stable to go home. That'll save them on hospitalization. All right, there's more stuff on croup. Epiglottitis, I think we've kind of gone through this a little bit more. We've talked about that pretty much at length already. Tonsillar infections, of course, those can be, usually are not that, they're not a life-threatening event usually, but they can be. Usually they're just viral and they're nothing, and you just have to, just treat the fever or whatever until it goes away. If it is strep, then you will want to treat strep with antibiotics. Mononucleosis can actually give you the worst looking throats you'll ever see. And of course, mononucleosis is a virus you're not going to treat with antibiotics, so it's going to depend on the causation here. Tonsillar abscess is something that you're going to want to refer over right away to get drained, because it can obstruct the airway, so you just want to be aware of that. And then the abscesses can be lanced, and I've never done one. I've heard about it. It just sounds perfectly horrible to me. I certainly wouldn't want to do it, and I would be very much afraid to do this in a child in a pediatric office without being able to be able to support the airway in case they got into trouble. But anyways, this is something, if you do see an abscess and that's a unilateral enlargement of one of the tonsils along with fever, that you're probably going to want to at least consult an ENT. And here's a picture. It's not a very good one of an abscess, but you can see where it's kind of that tonsil is very enlarged here. Bacterial tracheitis, we kind of talked about that a little bit already. Then you can have those retroperitoneal abscesses that can cause lots of different things. As far as like symptoms. And this is also going to be a pretty sick kid too, so you're going to refer this kid out or send him to the ER. Aspiration of the foreign body. Of course, you can have wheezing, gagging, that sort of thing. The most commonplace, for your anatomy, is your right upper lobe, your right mainstem bronchus to get any kind of anything lodged into. So if you have decreased airway, especially on your right upper lobe, then you're going to be more concerned about an aspiration, especially if you have a history of something. Well, I think you might have swallowed something, and now I've got wheezing, stridor, and decreased breath sounds in that area. Of course, the best way to figure this out is to get an x-ray. They do need to have a bronch to remove this. Angioedema, we've talked about that before. We talked about allergy response. So laryngomalacia is something you sometimes see. Sometimes it can be something that's going to need surgery or stretching or something else like that along the way, but usually it just resolves on its own. It's just a relative smallness of the airway, and you'll hear a little bit of stridor, especially if the baby has finished eating, but other than that, their O2 sats are normal, and they recover quickly. They're not getting in real trouble with it. If they get into real trouble with it, of course, that's a whole different story, and that needs to be, much further investigated. But if you just hear a little bit of a stridor in a baby, especially after they've eaten, that they don't seem particularly bothered about, that's probably what it is. But if you're not familiar with this particular diagnosis, you definitely want to get a second opinion to confirm that diagnosis before you just kind of like pass it off as this. Okay, so that kind of talks about it. It's just a functional type thing. The airway's small. And this is just the tracheomalacia. Now this is a bigger deal. Can be just kind of watched and grown into as well. But sometimes, and they've got surgery here, this is a really tough one to deal with. Sometimes they'll do something called a cricoid split, where they break open the cartilage bands around the airway. And this is kind of a big deal. You're probably not going to see this in your practice, but you may see kids that have had this done. It's super uncommon, fortunately. Then vocal cord paralysis. This can be temporary or permanent, and usually it is temporary though, and you can kind of work around it. Every once in a while they do need surgery, but they do have kind of like a stridor, kind of speech pattern or stridor when they're sucking as well. So that's why if you got the stridor and you're not sure that it's just small airways, they're going to outgrow it, then you do need to have an ENT probably look at this. Okay. Subglottic stenosis. Also probably something you're not going to see, but you're going to see kids that have had the effect of this one. This can be pretty serious and require surgery or dilation, but fortunately, once again, not super common. Choanal atresia, this is the one we talked about. This is when your nose is not patent. Hopefully you'll know about that before they get to you, but if they didn't, check this. So how we check this is you plug one nair and you close the baby's mouth and see if they can breathe. And you can do that on the other side. The other way to check it is to put an NG tube down both sides to see if you can pass an NG tube down both sides. Then you can have atresias and webs, and stenosis is everywhere, but those are kind of genetic problems that are going on. So, and we talked about obstructive sleep apnea, and we talked about snoring already. Okie dokie. So lower disorders, RDS and BPD and infection. Okay, so we've kind of talked about RDS already, not called hyaline membrane disease anymore. Don't call it that. I haven't seen that name in years. This is something about the pathophysiology. I didn't look through this in detail to see if it's accurate or not, but it's probably close for what you need anyways. So the treatment for surfactant deficiency is surfactant. This can only be given in the first 72 hours of life. This is something that is definitely going to take place in a hospital. You're not going to do this in the office at all. And it has to be given via an ET tube. I believe in your book somewhere it says that it's given through an NG tube. That is absolutely not correct. Giving the mom steroids prior to delivery helps prevent this because it causes like an increase or rapid maturation of the lungs in the baby, because because we really don't know why. But for whatever reason, a stressed baby is more likely to develop their lungs earlier. So a mom with like hypertension is going to have, their babies are less likely to have premature lung disease, along with some of our drug moms. Those babies usually do better as far as that goes. But like I told you, mothers with diabetes, that's a different story. They go the other way. Bronchopulmonary dysplasia is actually the byproduct of respiratory distress syndrome. So you have respiratory distress syndrome, and now you have damaged lungs. So this is kind of like the chronic part of this disease from the damage of trying to keep the baby alive to get over their respiratory distress, which is pretty much over by 2 weeks of age. Then you're moving into bronchopulmonary dysplasia. There's a bunch of definitions for this. A lot of it is like, basically, if they're still on oxygen at term, then they definitely meet it. There's some intermediate type disease processes, but you don't need to get into all that we call it or may not call it after the 2 weeks of age prior to term. And this is treated with supportive care, just trying to treat their respiratory distress until they grow into their lungs. Children keep developing new lung tissue to about 8 years of age. About 8-9 years of age, babies or kids in general have their full complement of lungs. That's why when you have a kid that has asthma as an infant, that once they get to be about that age, their asthma will go away. And it's not for some of the kids it is their asthma's gone away, and for some of them it's not because their asthma's gone away so much as that their lung capacity is increased to the point where they can deal with having the asthma or deal with some areas of collapse without having to stress, if that kind of makes sense. And then once their body grows into their lungs, their asthma will come back. So you'll see that. So other kind of infections that we have in kids, pneumonia is bilateral. We can have bacterial, viral, atypical pneumonias, which is the atypical is caused by mycoplasma. So the most common thing we see for sure is viral. With viral pneumonia, you'll usually hear wheezing, maybe some rales, whatever, but it's basically all over the lung fields. With a bacterial pneumonia, that tends to be more isolated, so that you'll just hear all those different lung sounds in a certain location, like say right upper lobe or left lower lobe, that sort of thing, rather than just kind of everywhere. That's kind of one of the hints between the two. If you get a chest x-ray, they'll talk about pneumonitis, and that's usually viral versus a pneumonia, which tends to be more bacterial if you see the report like that. And then you have aspiration pneumonias, which have a different look altogether. Usually there's a history of like an aspiration event, or you've got someone that's either cognitively impaired, that sort of thing, that can't protect their airway. Then you've got asthma and acute respiratory distress syndrome, which can affect adults as well. Okay. Bronchitis, just to let you know, is almost always viral. Does not need to be treated with antibiotics. Okay. And this talks about it being viral and bronchiectasis, which is usually related to RSV. RSV is one of those things in very young children, and kids less than a year of age, can be a very, very serious illness. In babies with BPD or that sort of thing, they do have an immune globulin that they can give to help. It doesn't really prevent the RSV, but it gives them some immunity, helps them fight the RSV, I guess. So it's not really a vaccine. It's called Synergist, is the brand name for it. It's super expensive. It's about $1,000 a month, and you have to give it exactly 30 days apart. But that does help if you do have a kid that's high risk. RSV, once again, is something that anybody can get. And usually the kids get it from a parent or older sibling or that sort of thing. And for most of us, it's just a cold, but for kids, it will cause wheezing. Really, in kids over a year of age or with pretty much normal lungs at that age, they're really not going to have much effect to it. They may have a little bit of wheezing, but they're not particularly bad. But on the very small children, especially the kids under 6 months of age, especially under 3 months of age that get RSV, this can be a very life-threatening type illness. And they need to be sometimes supported in the hospital on ventilators. So it just kind of depends. So during RSV season, if I get a very small child that has a cold-like symptom, that sounds like they got a cold during RSV season, I will bring them into the office the next day. I have found that they will usually get, if they haven't had any issues by 48 hours of age, they're going to be able to do well with this. But if that first day they may do okay, but by the second day they're in big trouble. So depending on the mom and how comfortable I feel with her being able to recognize symptoms, but I usually just get them in the next day anyways because it makes me feel better. A real high-risk situation, you may even want to admit this a small baby with a cold-like symptom. And then there are rapid tests, kind of like for strep, that you can do for RSV. We do them in our office, and then but those aren't always positive in that first 24 hours of life. So that's another thing going on there too. So just be careful of that one. Okay, it kind of talks about here, sometimes you need some oxygen. This can be a big deal. Talking about pneumonia, viral pneumonia, and some bacterial pneumonia, that sort of thing. Just kind of look through this real quickly. Atypical pneumonia, the walking pneumonia. Aspiration, we've kind of talked about this. Okay. So I think we've talked about most of this stuff. Asthma is a whole kind of different thing on its own. This is a disease of basically mucus and inflammation. Okay, so they have mucus blocking their airways, and they have inflammation. But the definition of asthma is that it is reversible. So if you have somebody with asthma and you treat them with a medicine like albuterol, which comes under a bunch of different brand names, they will get better. So you'll notice a decrease in their work of breathing. You'll notice clearer breath sounds. They'll report that they feel better. So, and there is some actual, if you're doing pulmonary function testing, you expect to see at least a 12% increase in their pulmonary function testing to know that, to give you the definition of asthma. We'll go over pulmonary function testing at a later date, okay? Because that gets kind of confusing if you don't do them a lot. And you really can't do pulmonary function testing on real young children, so you're going to do more with your physical exam, that sort of thing, okay? Okay, so asthma, and asthma is based, you have, mild intermittent asthma which is just what it says, mild and intermittent. Then you have chronic asthma states. So you go up to severe persistent asthma. And there's some guidelines to help you know which are which when you're treating those. You'll see those again this next summer when you do pediatrics. Okay, we'll talk about more about asthma. Cystic fibrosis, we've kind of talked about that before when we did genetics. Also, the big problem with cystic fibrosis, as you remember, I'm sure, is that you you don't thin out mucus. So your mucus is very thick and it plugs, and it can cause like pancreatitis and GI problems and lots of lung problems because of that. Okay, so just kind of look through these real quickly. And I think most of this you're kind of aware with. SIDS. Fortunately, we are seeing a lot less SIDS now that we do something called back to sleep, which is keeping the baby on the back all the time. So we want babies to never sleep on their stomach, ever. And it really, I can't tell you, when I see pictures of babies sleeping on their stomach, it makes me want to just throw up. Because we do know that that makes such a big difference to the rate of SIDS. Now actually not, because we're not seeing SIDS the way we used to. We're seeing a lot more rollover deaths. So babies never ever need to sleep in a bed with a parent. Alright, so they just have some case studies down there, but I think that's it. Thanks a lot.